Vertebral hydatidosis. Definition: Hydatidosis in humans is caused by the cystic stage of the tapeworm Echinococcus granulosus, which is endemic to the temperate climate. The life cycle of E. granulosus may also involve sheep, cattle, goats, and humans. This infection is transmitted via eggs shed in the feces of infected animals. Hydatid disease is not uncommon in the Saurashtra and Kutch areas of Gujarat state, where cattle rearing is a common occupation. Primary hydatidosis is common in the liver, spleens, and lungs.
Hydatid disease is caused by the larval stages of the echinococcal tapeworms. There are two different species of Echinococcus, E. granulosus and E. multilocularis. Definitive hosts of these parasites are animals in which the adult worms can inhabit and reproduce, and include dogs, cats, foxes, and jackals. In contrast, intermediate hosts are animals that can only be infected by the larval stages of the tapeworm, and not by the adult worms, and include humans and farm animals such as sheep, goats, and pigs. Both species of echinococcal adult worms have a similar appearance, but E. granulosus, measuring 2 to 7 millimeters and shown on the left, is slightly larger than E. multilocularis, measuring less than 4 millimeters and shown on the right. Adult worms are composed of a scolex, namely a head with hooklets, a mature middle segment, and a gravid posterior segment that produces eggs, as seen in the middle slide. The adult Echinococcus granulosus measures 2 to 7 millimeters long, as seen here on the left, and lives in the intestine of dog, as seen here on the right.
Applications in medicine. During the last 10 years, we diagnosed and treated 4 patients with spinal hydatidosis disease. The series include 3 men and 1 woman. They present with persistent blockage not responsive to usual conservative treatment and gradually increasing neurologic deficit of the lower limbs. 2 patients present with spastic paraplegia, one with impairment equal to American Spinal Injury Association, grade C, and 1 patient who had a surgery before being seen at our institution, presents with neurologic deterioration and caught echina syndrome. Risk of tapeworm infection is high among people with close animal contact.
The clinical manifestations of hydatid disease are primarily a result of mass effect by the slowly growing hydatid cysts. As a consequence, echinococcal infection is typically asymptomatic for years to decades, as the cysts themselves only increase 1 to 5 centimeters in diameter per year. The most common locations for these cysts are in the liver and lungs, but other organs, including the kidney, gastrointestinal tract, spleen, and soft tissues may also be affected. The liver is involved 50 to 70% of the time and is associated with hepatomegaly, right upper quadrant abdominal pain, nausea, and vomiting. In the event that the bile ducts become compressed, cholestasis and jaundice can occur. Moreover, if the portal and hepatic veins become compressed, then portal hypertension and Budd-Chiari syndrome may result. Liver cysts can also rupture, resulting in dissemination of protoscolices as well as cholangitis, pancreatitis, and/or peritonitis. Lastly, pyogenic liver abscesses may occur if hydatid cysts become secondarily infected by bacteria. The lung is involved 20 to 30% of the time and is associated with pleuritic chest pain, cough, dyspnea, and hemoptysis. Lung cysts that rupture may lead to pneumothorax, pleural effusion, and/or empyema. Other symptoms that may occur as a result of hydatid disease include flank pain and hematuria with kidney involvement, seizures and spinal cord compression with CNS involvement, and pathologic fractures with bone involvement. Lastly, cyst rupture can trigger a severe host inflammatory response associated with anaphylaxis and multi-organ failure.
Pros and cons. In all patients, histopathologic confirmation of the diagnosis was obtained and antihelminthic therapy with 400 milligrams of albendazole 3 times daily was prescribed for 1 year. The patients were followed every 6 weeks initially in the form of neurologic reassessment and imaging investigations. 2 patients who developed symptomatic recurrence were treated by repeat surgery for through decompression and fusion with iliac crest bone graft through the anterior approach. They were rehabilitated at our spinal care center, including post-operative care and gradual mobilization with spinal braces.
Hydatiditis disease is diagnosed with a combination of radiographic imaging and serologic testing. Ultrasound is widely utilized to screen for Hydatiditis disease given its accessibility, ease of use, and relatively low cost. As a diagnostic modality, it has high sensitivity ranging from 90 to 95%, but its specificity is lower given that it can be difficult to distinguish Hydatiditis cysts from benign cysts, abscesses, and neoplasm. However, presence of Hydatiditis sand, the visualization of the protoscolices within the cysts, would certainly clinch the diagnosis. CT is a study of choice for Hydatiditis disease. Not only does it have higher sensitivity ranging from 95 to 100% compared to ultrasound, but it is also better able to determine the size, number, and location of the cysts. If the etiology of cysts seen on radiographic imaging is uncertain, serologic testing for Echinococcus can confirm the diagnosis. ELISA can detect the presence of antibodies against Echinococcus with both high sensitivity of 94% and specificity of 99%. Based on radiographic imaging, the WHO classification system divides Hydatiditis cysts into 6 different stages to help guide treatment. WHO stage Cystic Echinococcosis 1, or CE1, is a unilocular cyst, while Cystic Echinococcus 2, or CE2, is a multiseptated cyst with daughter cysts. Both of these stages are considered early stages when the parasites are active. WHO stage Cystic Echinococcosis CA, or CE3A, and Cystic Echinococcosis CB, or CE3B, represent cysts with detached membranes and daughter cysts, respectively. These stages are transitional ones between live and dead cysts. WHO stage Cystic Echinococcosis 4, or CE4, is a cyst with heterogeneous contents, while Cystic Echinococcosis 5, or CE5, is a solid cyst with a calcified wall. Both of these stages represent dead cysts. This CT image demonstrates a WHO stage CE1 Hydatiditis cyst that is unilocular with an absence of daughter cysts. CT image in the upper left corner shows a WHO stage CE2 cyst that is multiseptated with daughter cysts as indicated by the arrow. The plain radiographic image in the lower right corner demonstrates WHO stage CE5 dead cysts with calcified walls in the liver. These images demonstrate Hydatiditis cysts in the lung, shown here on the left, and in the brain, shown on the right.
Issues applied in Ecuador. All of the patients were investigated with routine hematologic investigations including blood counts, plain radiographics of the spine in anterior, posterior, and lateral views, and underwent ultrasonographic examination of the abdomen to rule out visceral Hydatiditis disease. All of the patients present with neurologic complications. 2 patients underwent conventional myelography. 1 patient underwent a computerized tomography scan and magnetic resonance imaging. In the 4 patients, one investigated with post-myelography, CT scan, and an MRI scan.
Echinococcal infection is distributed in South America, Europe, southern and central Russia, Central Asia, Australia, and Africa. The risk of infection is highly influenced by the extent and nature of human association with dogs. The parasite is widely prevalent in regions of the world where dogs are used to care for large flocks of sheep. This map illustrates the global distribution of both echinococcal species, with E. granulosus represented by regions marked in black and E. multilocularis marked with an X. The relationship between Echinococcus and its intermediate and definitive hosts is relatively straightforward. Adult worms inhabiting the small intestine of the definitive hosts release eggs in the stool. These eggs are then ingested via fecal-oral transmission by the intermediate hosts, allowing for the eggs to hatch and larvae to penetrate the intestinal wall. Once inside, the larvae are taken up in the bloodstream and distributed to the liver, lungs, and other organs, where they form hydatid cysts that enlarge slowly over time. Definitive hosts become infected when they ingest these cysts, for example, a dog consuming the infected viscera of a sheep, allowing for immature protoscolices from the cyst to attach to the small intestine of the definitive host and mature into adult worms, completing the life cycle. Hydatid cysts are composed of 3 layers. The pericyst is the outer layer, consisting of modified host cells, fibroblasts, giant cells, and eosinophils, which together form a rigid protective layer and represents the host response to the parasite. The exocyst is the middle laminated membrane of parasitic origin, permitting the passage of nutrients from the host to the parasite. Disruption of this membrane predisposes the cell to degeneration, death, and bacterial infection. The endocyst is the inner germinal layer. Immature protoscolices multiply within outpouchings of the germinal layer, known as broad capsules. Daughter cysts, smaller hydatid cysts derived from the primary mother cyst, may also develop within the endocyst. This photo shows the typical appearance of the laminating membrane of a hydatid cyst which has been removed surgically.
Conclusion: Hydatid disease is not uncommon in rural areas of Gujarat state. It is acquired in childhood and usually presents in adulthood. Musculoskeletal involvement is a less common presentation, of which spinal involvement is frequent. The infection may be misdiagnosed initially as tuberculosis of the spine, which delays proper diagnosis and intervention. In addition to the many difficulties in the diagnosis, the management of the disease is even more challenging because of a high recurrence rate, requiring extensive and repeated spinal surgery, with high rates of complications and significant long-term morbidity and mortality. Results are seldom satisfactory and prognosis is usually poor. Control of conditions favorable to tapeworm transmission is a key to preventing hydatidosis in humans.
Treatment of hydatid disease is based on disease stage and cyst size. For inactive cysts, or CE4 through 5, no treatment is necessary and only observation is warranted. For active and transitional cysts without daughter cysts, or CE1 and CE3A, treatment is dependent on the cyst size. Albendazole alone is the only therapy required for cysts under 5 centimeters, while albendazole with puncture, aspiration, injection, and reaspiration, or PAIR, is necessary for cysts greater than 5 centimeters. Albendazole is dosed 10 to 15 milligrams per kilogram per day in 2 divided doses for 1 to 6 months depending on treatment response. PAIR is a percutaneous intervention where the cyst is punctured under ultrasound or CT guidance, its contents aspirated, then injected with a protoscolicidal agent such as 30% saline or 95% ethanol, and reaspirated. This process of injection and reaspiration is repeated until no protoscolices are present in the contents of the cyst. Pear has a greater than 95% cure rate in Hydatiditis disease without daughter cysts. For active and transitional disease with daughter cysts, or CE2 and CE3B, treatment involves a combination of albendazole and either modified catheterization or surgery. Modified catheterization is a percutaneous intervention whereby the mother and daughter cysts are removed using a combination of drainage large catheters and aspiration devices. The image on the right demonstrates the surgical resection of a large mother and multiple daughter cysts from the kidney, and the left photo shows multiple resected hydatid cysts.